Hello, everyone. Good evening, and I have with me today for the IFSO webinar Professor Antonio Iannelli. He is from the University Hospital in Nice, from the south of France, and he is a bariatric and a liver transplant surgeon with the digestive surgery department. And very recently, they published a very important study, which is titled as Systematic Endoscopic 5 Years After Sleeve Gastrectomy Results in a Rate of Barrett's Esophagus, Results of a Multi-Center Study. So first of all, congratulations, Professor Iannelli, on such an important study. I think this was much needed and very, very important. So I would like you to request you to speak a few words about the study. If you can just elaborate in short about the study that you have conducted.
Thank you so much for the invitation. Just to be short about the study, as you know, there have been two studies before this one,
Yes,
focusing on the problem of Barrett's esophagus in sleeve gastrectomy patients. So one had a follow-up around 5 years, another one at 10 years from Austria. Another one was an Italian study, but both studies were essentially monocentric series. And what
yes,
we wanted to do is to do a study including centers of reference, but from two different countries and from different bariatric surgeons, just to avoid the potential bias of the surgical technique, which actually, as you know, changes from one center to
yes,
another, although for small details. But there are some surgeons that are pushing the dissection more on left, more behind the esophagus. Others are looking for the hiatal hernia. What we wanted to do is to include patients from heterogeneous centers and
yes.
just to avoid this. And so we chose uh, 5 centers, the centers that positively accepted the invitation. I have to say that I was sent an invitation to other centers, but as you know, people are most of the time overbooked and could not provide
Yes,
enough patients.
yes,
And these centers provided us with a variable number of patients. We were supposed to have a 100, but at the final analysis, we only had 90 patients. But this is a
right.
quite important number of patients. And this was a young surgeon that was starting his training in bariatric surgery and digestive
Yes,
surgery with me. That's the first order that
yes.
actually did the most of the study. I only supervised the study,
Okay.
just getting the data in. That was the most difficult part of the story.
That's really great, Professor. So, w- how did the idea come about? Who designed the study, and how did this idea come to you people?
I actually designed it myself the study because the design is quite simple. We wanted to have quite long follow-up. We didn't want to
Yes.
go up to 10 years because 5 years seem to be a reasonable period of time to develop metaplasia in patients who were supposed not to have any esophageal lesions before surgery.
Right.
What I have to say is that we decided to involve centers in which patients have the endoscopy
Yes.
at the hands of specialized endoscopists, as it is the case for our patients. In other words, the endoscopist who did the second endoscopy was the one who made the first one. I mean, at least in the
Okay.
same centers. So going through the same protocol, because one problem could be to have patients who had already metaplasia at baseline. So
Yes.
this is why
Yes.
we did not take any patient from anywhere for any surgeries. We only took patients that had the first surgery in the place where they had the first endoscopy and in the center that was involved in the study. And
That's
then
right.
the endoscopist in our center, who is a guy who is special interest in Barrett's esophagus, actually helped me to define the criteria for the diagnosis of metaplasia. So, for example, the duration of endoscopy was, in all cases, at least in this,
Right.
around 10-15 minutes.
Okay.
I left this to the Dr. Van der Viet, that is the third author, who designed
Yes.
who made the endoscopic design of the study.
Right. Thank you so much. And there's a very interesting finding between weight loss failure and Barrett's esophagus in your study. I think this is the first time that we've observed something like this. Would you like to elaborate a little bit on it? And I think we can discuss in detail during the webinar.
What may seem surprising in this study is that in multivariate analysis, GERD is not a risk factor. This is simply
Yes.
because GERD is so common after sleeve gastrectomy, at least GERD symptoms. GERD
Yes.
symptoms. Uh,
Yes.
but what came as an interesting information is that patients with failure actually
Yes.
have, in the multivariate analysis, an increased risk of Barrett esophagus. So now we only can make speculations to find a potential explication for
Yes.
this data. And the one potential problem is that patients who have failure actually are those who remain obese, and as
Right.
obesity is a risk factor in itself for the Barrett esophagus. In
Yes.
other words, those who have good weight loss probably have all the advantages of
Correct.
weight loss. It is also reduce the risk of some cancer. You know,
Right.
this is
So,
one potential explication. The other explication is that maybe this patient less reflux, those who have a good weight loss. Instead, patients with weight recurrence most of the times have increased symptoms of reflux and maybe more esophagitis. We could not confirm this, but
right.
the only potential explication that we found was linked to the fact that obesity is a risk factor for morbid obesity
Right.
for Barrett esophagus.
Okay. And there was also another mention in the study about the difference in the rate of adenocarcinoma in normal stomach as compared to the post-sleeve stomach. So, would you want to say something about
Yes.
that?
Also,
Because that would be a very important point for
yes.
everyone.
This is an interesting topic, but we remain in the speculation domain actually,
Yes.
because what we were thinking about this was that um, patients with sleeve gastrectomy rarely, if not never, how many cases of esophagus carcinoma, adenocarcinoma we have in the literature? Very, very few.
Yes.
Now the
Yes.
follow-up is still short for
Yes.
carcinogenesis, but still,
Yes.
the gastrectomy exists since more than 25 years as a
Absolutely.
first step of
Yes.
duodenal solution. So now,
Yes.
if I look simply at this phenomenon, one may speculate that these are not the same patients. First,
Yes.
they may have a component of weight loss that may
Yes.
play a role. Second, these patients probably have a different uh, gastric content that comes in contact with the esophagus. In other words, maybe the pH is different. Maybe there
Yes.
is no bile or there is more bile. I don't know. But
Yes.
one potential explication is that as the fundus has been removed, the gastric content is not the same as a normal in patient with a
Correct.
normal stomach. Uh,
Right.
the other thing is that probably these patients have changed their eating and also smoking habits.
Yes.
Removing alcohol, tobacco, uh, all things that may play a role. But again, all these remain in the domain of speculation.
Exactly. Thank you so much. And I think one last question before we actually move on to the final webinar on the 27th would be that what would be the implications of your study into clinical practice for bariatric surgeons?
I think that bariatric surgeons should be aware of the risk of bariatric esophagus. Now,
Right.
uh, one thing that must be said is that uh, we don't want that bariatric surgeons believe that sleeve gastrectomy is a dangerous operation
Right.
because we do not have cases of adenocarcinoma. So
Yes.
some gastroenterologists are saying you will see all these cases in the future. I'm not that sure. I'm not that
Right.
sure. But still,
Right.
the most important thing is that a systematic endoscopy should be probably
Yes.
done beyond 5 years. So what I
Right.
do now in the current practice in France, the SOFCO, that is the Bariatric Society of the Society of Bariatric Surgery, plan to do at 1 year, 3 years, 5 years, 10 years. I think that
Yes.
more than 5 years, after 5 years, that's a good idea. We have
Okay.
around 40,000 CGSAT in France every year. Doing
Okay.
systematic endoscopy every year is not cannot. It's not a good idea. But
Correct.
the true message is do an endoscopy. If you find a Barrett, then you have the choice to make follow-up, endoscopic follow-up, to remove
Right.
endoscopically, or even doing a gastric bypass in patient, for example, with weight loss failure.
Right. Thank you
These
so much, Professor.
are the main conclusion of the study. Thank you to you
Thank you
for
so much.
inviting.
Yeah, and we really look forward to the 27th of February, where we will have a detailed presentation by your team, and we can discuss all these points in detail. And having said that, I think this is one of the most important papers published in the recent times. So thank you very much.
Thank you so much. Thank you so much for the invitation. So I'll meet you again on the 27th. Have a nice day.
Yes, you too. Take care. Bye.